Thank you for joining us today. I want to welcome everyone to this installment of the STS 2022 Webinar Series. This series features presentations and panel discussions on a variety of topics relevant and important to cardiothoracic surgeons. The topic today is understanding and implementing the new CoC lung cancer standards. STS is grateful to AstraZeneca for their support of this webinar. Please note this webinar is being recorded and will be available tomorrow morning on the STS website and YouTube channel. At this time, I'm pleased to welcome Dr. Linda Martin, who has organized this session. Dr. Martin is Associate Professor of Surgery at University of Virginia School of Medicine and Interim Chief of the Thoracic Surgery Division of UVA Cancer Center. Dr. Martin, welcome. I'll now turn it over to you.
Thanks, Wes. Well, welcome all of you to the STS webinar on understanding and implementing Commission on Cancer Standard 5.8 for lung cancer surgery. We're going to talk about optimizing quality of surgical lymph node assessment in conjunction with lung cancer resection. I'm Linda Martin, and I serve as the Society of Thoracic Surgeons representative to the American College of Surgeons Commission on Cancer. I've also been a contributor to the Operative Standards for Cancer Surgery project, and I've been involved in dissemination and implementation committee to help get the word out and help everyone learn how to do a higher quality cancer operation. Tonight, we will hear from a world-class panel of experts about lymph node assessment and surgical management of lung cancer. What is Standard 5.8? How can you implement it? And what is the science behind it? Also, how does it interface with other quality improvement initiatives? This panel is going to educate us about the standard and why it exists, and we'll hear brief presentations from each of the panelists and then have a discussion and question and answer session. I'm going to introduce each of the panelists and their background and their interest in the subject. So the first panelist is Dr. Nirmal Veeramachaneni, who is editor of the lung cancer surgery section for Operative Standards for Cancer Surgery, Volume 1, and has also served as the co-editor-in-chief of Volumes 2 and 3 of the Operative Standards project, and is the incoming chief of thoracic surgery at St. Louis University. Tonight, we'll also hear from Dr. Timothy Mullett, who is a professor of thoracic surgery at the University of Kentucky and serves as chair of the Commission on Cancer. Dr. Matt Facktor is the system chair of thoracic surgery at Geisinger Heart and Vascular Institute, and also the former chair of the Cancer Quality Integration Committee for the Commission on Cancer. Dr. Gail Darling is joining us as the newly named professor and head of surgery at Dalhousie University in Nova Scotia, Canada. She was a lead investigator of the American College of Surgeons Oncology Group Z30 trial that evaluated the role of node sampling versus dissection in early stage lung cancer. Next, we have Dr. Dan Boffa, who is professor and chief of thoracic surgery at Yale University and chair of the Quality Integration Committee for the Commission on Cancer. And then Dr. Mike Archer, who is an assistant professor at SUNY Upstate in thoracic surgery, and he serves on the Education Committee for Cancer Surgery Standards Program for the American College of Surgeons. Next, I'd like to preface our discussion with two quotes that help put the importance of these efforts into context, and I think sort of a motivation for why we should be looking at improving cancer surgery standards. I'm going to show you these slides in just one moment here. With me, here we go. So the first quote is that comes from over 100 years ago. People never improve unless they look to some standard or example that is higher or better than themselves. And that's a little hard to swallow sometimes, but I think it's true that we have to have something to work towards. And then the other quote that I love is from Dr. Frank Detterbeck, and this was in the opening to the first volume of the Operative Standards for Cancer Surgery. And the way he described this project is the purpose is to describe a minimal standard for the actions that should be taken in surgical care of lung cancer patients, with the ultimate goal of improving the quality of care these patients receive. In this way, the aim is to raise the floor rather than to define the absolute ceiling of what can be achieved. Further improvement is always possible. So we're looking at how we can raise cancer care across the board, not just at the best centers, but everywhere that lung cancer surgery is performed. And with that, I'll turn it over to Dr. Timothy Mullett, chair of the Commission on Cancer, and he's going to give us some introductory remarks about the mission of the Commission on Cancer and some of the background for the standards.
Linda, thank you very much, and thank you for the opportunity to be able to share some of this. I think this is a key feature for us to be able to understand why we need to make these changes. And Dr. Detterbeck really said it very well in that description in the original text. And I won't, again, this is for all surgical case, all surgical cases being performed for curative resection. And so it doesn't matter the context in terms of what facility, it doesn't matter the context in terms of which surgeon. The important thing is for all of these cases to be raised to a level that we should all be proud of. And really, this came from the descriptions and the work that you led, worked on, Linda, as well, with the operative standards for cancer surgery. And these published texts, and now there's 4 volumes, have been the standard, the evidence-based standard for what should be performed in cancer operations. And so these standards, such as 5.8, have come from these descriptions and from the text to be able to put them into application, because it's, again, putting it into a standard puts all of the accredited programs on the same footing. And really, when we've begun this project, and it is a beginning, we have started with 6 standards, and 5.8 is one of them. It's the lung standard. There's also a standard in melanoma, 2 standards in breast, a standard in colon, and 1 for the rectum. And so the surveyor for these cases at all of the Commission on Cancer accredited programs, and 1,500 of them across the country, are all going to be looking for the same pieces of information. This relates to our expectations for the lung, in the sense that this is going to be examined in the pathology reports. There's going to be more descriptions throughout this hour to be able to give you specific information about this, but I just want you to realize that the site reviewer is going to be examining these programs based on the pathology report. And so what happens in the operating room is going to be reflected in the pathology report. And that's, in the case of standard 5.8, that's how this is going to be judged for compliance. The other, the rectal standard is the same way, and those pathology reports are already being reviewed. The other standards in colon, breast, melanoma are reliant upon a new document called the Synoptic Operative Report that is related to the operative standards for cancer surgery, but it is not related to the lung standard. So while your program may be generating synoptic operative reports, it is not either impactful or anything that is going to slow down your ability to be measured and to be judged for compliance in your lung resections. These operative standards implementation was really something that came forward from the Cancer Research Program and ultimately developed into the Cancer Surgical Standards Program, and the chair is Dr. Matt Katz. This is a chart that shows, again, the 6 operative standards that are currently active, 5.3 through 5.8. 5.3 through 5.6 are the standards that are going to be measured by the operative report. That is the synoptic operative report, which will be described in other venues and is not related to the lung resections that we'll be talking about today. All of these pieces of information are both coming from the operative standards for cancer surgery, and the specifics of the standard are described in the Optimal Resources for Cancer Care, the current manual for the Commission on Cancer standards. Standard 5.8 for lung is any procedure that's performed with curative intent for lung cancer is going to be measured based on what's described in the pathology report. And that pathology report measurement begins from 2021. So site reviews that are happening this year are looking back into 2021, and they're expecting to see 70% compliance of 7 charts that are going to be examined at random from your program performed in 2021. They specifically, again, are looking at the synoptic pathology report, and that will be described. You have to have 70% of 7 of those charts that are compliant with the measure, as will be described in today's session. So why are we moving in a direction of synoptic reporting at all? And again, I think that this is something that we learned from the synoptic pathology reports and how impactful that was years ago when the Commission on Cancer established that all accredited programs needed to use synoptic pathology reports. When we generated those path reports in a format that was a series of checklists. It's a question followed by an answer. Are there margins, positive or negative? Description of grade, description of other elements of the tumor. And so these are checklists that have been structured now, and all programs are using that. And that's because that was a standard set in place. Synoptic operative reports are critical because they are ultimately going to lead to increased adherence to surgical standards. And it's going to be a formatted structure for the operation, and it's going to describe this in a checklist format versus a narrative description. It's going to be easier for us to find the information, easier for research to be able to be conducted on the quality of operations in regards to outcomes that are ultimately going to improve. I mention this because lots of folks are asking questions about why we are moving towards synoptic operative reporting, and it's because we're going to get to a measure of increased structure, universal language, and that's going to make it easier in terms of describing the key features of operations that have been performed. The synoptic operative reporting is going to be critical as we move forward. And remember, this is not required for the lung standard. It is required for the others, and it will be required for a series of surgical procedures that are ultimately going to come forward as we continue. We are in the first phase of synoptic operative reporting, and we're continuing to develop mechanisms for being able to describe these reports. We anticipate that there will be a comprehensive set of synoptic operative reports that are ultimately going to lead to better content and better description of all of the surgical procedures we perform. And once this is universal, supported by electronic medical record integration, we're going to see this as a tool that is as powerful as the synoptic path reports that we're all familiar with and frankly rely upon that structure. So that's where I wanted to start today, to make sure that we had a good understanding of why we are using these surgical standards, because we're trying to develop that standard procedure that's going to be performed. We're documenting that in the pathology report, and we're measuring that even today. And it's a critical step for us to be able to have more consistency in the surgical procedures that are performed. And right now, we need to address that inconsistency that's represented by many different procedures. Linda?
Before we turn it over to our next speaker, can you give us a little bit more of an idea about why does an institution want to have Commission on Cancer accreditation? What does it mean to surgeons, patients, the hospital, and the communities that they serve?
Well, sure. The Commission on Cancer is a consortium, really, that's housed in the American College of Surgeons, but at the same time, it represents the full spectrum of care in a multidisciplinary fashion. It is also inclusive of member organizations, of which there are about 60 that represent the spectrum of specialties, advocacy organizations, or government organizations, National Cancer Institute, American Cancer Society, a number of other advocates that are present, patient representatives, and so forth. And the important piece of that is that we are able to, along with the 100 or so representatives from the American College of Surgeons across the spectrum of cancer cases that we take care of, we're able to evaluate cancer care across its continuum. Standards have been developed to be able to raise the floor, I love that term, and to be able to see us move in a direction where all of the programs that are seeking accreditation are going to be measured at by the same standards. Whether you're a small program, a large program, a network program, everybody has the same expectations. And so this is a measure of the competency of your surgical staff, the competency of nursing, a measure of the data collection that you have. And ultimately, the reason for accreditation is to be able to say that you represent the quality in cancer care. And it's not just surgery, it's how you're delivering your medical care, your radiation therapy, how you're delivering your survivorship for patients, and as well as supportive care with nutrition rehab services, and all of the elements that are important in being able to help improve the lives of our patients. It's one of the key features that we have is leaning on multidisciplinary care. And so the idea of tumor boards and the idea of being able to have defined representation from all of the members of the cancer program on the cancer committee are all consistent across each of our programs. And so accreditation is seen by institutions as a mark of quality. It's seen by patients as a measure of a quality institution for performance of cancer care. And I think that we all look at this as a way to be able to say this is a consistency that we can share. And that's why if everyone's hanging the same sign of Commission on Cancer, we want this level of quality to be represented in each of these procedures. And this is a great way for us to be able to develop this consistent surgical procedure, identifying the key elements that represent quality features that lead to better outcomes. And that's what we're trying to get to.
Great. Thank you so much. Well, next we're going to hear from both Dr. Matt Facktor and Dr. Michael Archer, and they're going to give us an in-depth review of exactly what is Standard 5.8, with the hope that you're going to leave this webinar tonight with a very clear understanding of how you can comply with this and optimize the quality of your lung cancer surgery. I'll turn it over to Dr. Archer and Dr. Facktor.
Thanks so much, Linda. I really appreciate the invitation to participate in the talk tonight. As mentioned, we're going to start by discussing some of the background and rationale behind Standard 5.8. So as some background, in June of 2020, the American College of Surgeons launched the Cancer Surgery Standards programs in light of growing evidence that adherence to specific operative techniques during cancer surgery directly improves key patient outcomes, including survival and quality of life. In keeping with the American College of Surgeons Commission on Cancer's commitment to innovation and delivering the best possible care, accreditation standards have shifted from those based in facilities and equipment toward outcomes-based standards. So operative standards have been proven to improve cancer-specific survival. In this retrospective review of the National Cancer Database by Zoe and colleagues, their team investigated the survival outcomes related to specific operative standards in breast cancer surgery. Specifically, they examined standards regarding lymph node management for both sentinel lymph nodes as well as axillary lymph nodes. And notably, their report did note that more than 20% of patients did not complete the set of standards. Their study did show, however, that there was a clear survival advantage for patients with early stage and locally advanced cancers when operative standards were met. Data from this study and similar studies have driven the more recent iteration of operative standards in cancer surgery in order to improve patient outcomes. As mentioned by Dr. Mullett, in the 2020 Commission on Cancer Accreditation Standards, 6 new operative standards for various disease sites have been developed and will be assessed during accreditation evaluations. Notably, these operative standards were developed from the operative standards described in the Operative Standards for Surgery, volumes 1, 2, and 3, a publication that's developed based on evidence-based assessments by experts in their respective fields. As you can see, the standards 5.3 to 5.6 revolve around synoptic operative reporting, while standards 5.7 and 5.8 are captured in the College of American Pathology synoptic pathology report. The main goals of the Cancer Surgery Standard Program and the integration of the standards into the CoC accreditation process are to educate surgeons on the key technical aspects of the operative standards and to create tools which empower accredited programs to implement and adhere to the 6 operative standards. So CoC standards in lung cancer are not new. And in fact, prior iterations of the optimal resources of cancer care included standards for lung cancer, including resection of 10 or more regional lymph nodes at the time of surgical resection in lung cancer, as well as standards revolving around adjuvant and neoadjuvant therapy. Unfortunately, the adherence to the 10 lymph node standard has been historically low. In an assessment of the National Cancer Database from 1998 to 2011, this demonstrated that only about 1/3 of patients had more than 10 lymph nodes harvested. On a more recent analysis of lymph nodes performed during lobectomy from the STS General Thoracic Database, this noted some improvements with up to 44% attaining 10 or more lymph nodes at the time of lobectomy in low volume centers, and then up to 74% in high volume centers. Statistics that are improved, but a bit surprising given these are from General Thoracic Surgery database participating institutions. Dr. Osa Garbian investigated a possible reason for some of the relatively poor adherence, and audits from his group and others have described discordance between what has been described in operative reports and what is described ultimately in pathology reports. Other issues were ultimately noted to arise with regards to the accuracy of harvesting and labeling of the resected lymph nodes. For example, lymph nodes being removed piecemeal and then being labeled each as separate lymph nodes. So as the CoC, the Commission on Cancer and the Cancer Surgery Standards Program sought to establish an updated standards for lung cancer surgery, focus turned towards surgical staging of the mediastinum at the time of curative intent lung cancer resection. And as our audience knows, this is an important shift as lung cancer staging is dependent on the status of N1 and N2 lymph node stations and not the total number of lymph nodes harvested. And as Dr. Darling will review later, the ACOSOG Z0030 trial demonstrated equivalent survival between systematic sampling and lymph node dissection, and thus established the cornerstone for standardization of mediastinal lymph node assessment in lung cancer surgery. Although examination of at least 3 mediastinal lymph nodes has been recommended by the NCCN as one of their 4 quality resection criteria, mediastinal lymph node examination is not yet universally performed. An analysis of the SEER database in 2012 found that no mediastinal lymph nodes were examined in upwards of 13% of patients undergoing resection for non-small cell lung cancer. And compared to patients who underwent at least resection of 1 mediastinal lymph node, there was about a 14% difference in lung cancer-specific survival when this was adjusted for confounders. In a later analysis of a Mid-South quality resection database from 2004 to 2013, investigators found that only 17% of resections met all 4 NCCN guidelines, largely driven by the fact that only 26% of patients received adequate mediastinal lymph node assessment in the form of 3 or more mediastinal lymph nodes. We can see the large impact of following NCCN criteria has had on survival with a adjusted hazard ratio of 0.64. Clearly, implementing a CoC standard that mandates mediastinal lymph node examination will be beneficial for patient survival. Critical elements regarding lymph node staging include a rigorous preoperative clinical staging of the mediastinum, including the use of invasive mediastinal staging for central tumors, clinical N1 disease, and tumors greater than 3 centimeters, as well as for resectable limited stage small cell cancers. Importantly, lymph node staging at the time of operation should confirm preoperative clinical stage. Standard 5.8 specifically focuses on the importance of mediastinal staging done at the time of lung resection. The standard applies to all operations performed for curative intent patients with non-small cell lung cancer, limited stage small cell cancers, and carcinoid tumors, and includes all of extensive resection, including segmentectomy and wedge resections. I'll now turn things over to Dr. Facktor, who will describe the details of the standard and how compliance will be assessed. Dr. Facktor.
Well, thank you, Dr. Archer. I just have a few slides to cover here, and some of which is repetitive, as you've already heard. But to quote what's already been quoted, the intention here is to raise the floor. So this is not a ceiling, but this is where our floor should be. And it's informally referred to as the 1+3 rule. So at minimum, we should be harvesting at least 1 hilar lymph node. And at minimum, we should be sampling or dissecting nodes from at least 3 different distinct mediastinal lymph node stations. And as you just heard, this is for any curative intent lung resection, and that could be small cell, non-small cell, or carcinoid. To get more specific, and just as sort of a reminder, this diagram maybe not anatomically correct with the left on the left side of the screen and the right on the right side of the screen, but on left-sided resections, mediastinal lymph nodes, of course, include from 2 all the way up to 9. We all know that 2 and 4 and even the 3s are somewhat rarely found on the left-hand side, but they still would count if you encountered them. 4L being the most common of that group. And then, of course, 5, 6, 7, 8L, and 9L, all very common lymph node stations on the left-hand side for mediastinal. On the right-hand side, similarly, 2, 3, 4, 7, 8, and 9, as we all know, Important to remember the 3A and 3P, and Dr. Veeramachaneni is going to kind of go over a little bit of that a little bit later today in a wonderful video that's been produced. But those are all mediastinal lymph node stations. And we want to be sure we're sampling from at least 3 of those, whichever side the surgery may be on. And then, of course, these are all single-digit lymph node stations. And it's incumbent upon the surgeon, as well as the operative room team, whomever that may be, to label those lymph nodes correctly. And of course, primarily it's incumbent upon the surgeon, us, to convey the labels for our lymph nodes. And then double-digit numbers are Hyler lymph nodes, starting at 10. And for most of us, 10s, 11s, and 12s are what we get out during surgery. And then 12s and up will possibly also be in the specimen itself, depending upon what it is that you're removing. So 1 Hyler station at minimum and 3 mediastinal lymph node stations at minimum, 1 plus 3. Let's just take a look at at how you meet compliance and the timeline. So as we've said, the hilum and the mediastinum should be thoroughly staged at the time of a curative intent pulmonary resection. And this would even include a wedge resection. The surgical pathology report is the key. This is where the standard will be measured and where it will be assessed. And that pathology report is where we must see the lymph nodes from at least 1 Hyler station and at least 3 distinct mediastinal stations. And those must be listed on the pathology report in synoptic format, which coincidentally is a requirement anyway of the College of American Pathologists. So it affords our site reviewers an opportunity to, in a way, be checking on that standard as well. So these should all be very standard for curative intent operations. So the site visit reviewer is going to look at the pathology reports, and that is how they will determine if we are compliant. They are not looking at operative reports, but just looking at pathology reports. And for institutions being reviewed this year, for example, my institution, this year's site review will reflect last year's work, 2021, in regard to this standard. So I will be expected to have 70% compliance for my cases last year. Starting this year, 2022, I should have at least 80% compliance, although that won't be reviewed until next year, and we'll see that on a slide coming up. So this year, we expect to look back to 2021 and see at least 70% compliance. And then starting this year, any operations being performed now and into the future, 80% compliance. And the point here is, notice it's not 100%. Nothing should be 100%, and we all have exceptions for a variety of reasons, but you know, it's the good old 80-20 rule. We pretty much at least 80% of the time ought to be getting 1 plus 3. Here's a look at the timeline, and Dr. Mullett showed this slide as well. So if you look at 2022 in the middle of the slide, that's where we're all living right now, of course. But if you're getting a site review this year, they're looking in the past at last year for 70% compliance. And the remaining years, for at least the next few years, 80% compliance will be the threshold. It may be altered after that. And the Commission on Cancer will be monitoring national compliance to also better understand, is 80% the right number, since that's not specifically scientifically defined, but again, it feels right. And we know that most of our operations should harvest 1 plus 3 lymph nodes. And I think, is there one more? Nope, and that's our references. Thank you.
Great. Well, thanks, Dr. Facktor and Dr. Archer. That's really helpful for us to hear about. And then Dr. Veeramachaneni is now going to tell us a little bit more about the nuts and bolts of how to do this in the operating room and some really nice visual aids that he's been working to develop to help educate us, our residents, and our operating room staff on what the stations look like in the operating room instead of on a cartoon that's pasted to the wall in your operating room, hopefully.
Well, thank you very much. This has been over 10 years in the making as a large group of us worked on best practices for lung cancer operations. So before I get into the nuts and bolts of how to go about this, I just want to clarify that there is really a need to do some educational intervention as well. Our colleague, Jeffrey Yang at Massachusetts General, he did the lion's share of this work. And what we did was ask the simple question: surgeons who self-report performing lung cancer operations, how good at they are at identifying mediastinal lymph nodes, and how good at they are at identification for individual nodal stations. So what Jeffrey did was he went through CTSNet and identified the email addresses of essentially all surgeons who listed that they did some form of thoracic surgical work. And then we sent them a survey, and it was fairly straightforward. We offered intraoperative photographs, and we asked them what station were they looking at. And I'm going to share some of those results. Jeffrey had presented all of these data at the last STS meeting, so this is a very abbreviated version of his presentation. And we know that this is important. I'm not going to go over the same data again. We follow the standard ISLAC lymph node map for definition of lymph nodes. And these were some of the basic questions. For example, in question 1, which nodal stations are exposed with this view of the right inferior pulmonary ligament? And we defined the respondents according to how they self-identify. They were either general surgeons, cardiothoracic surgeons with more of a cardiac surgical practice, or more of a general thoracic surgical practice. So different questions got a different rate of response for accuracy amongst the 3 different specialties. For station 7, for example, this question caused difficulty for a number of people. Others more or less frequently encountered stations such as level 3A were also difficult for those who don't do a great deal of general thoracic work. The same for level 2R and 4R. Again, here's another sample question. As a synoptic of our data, very few of the respondents actually got all 7 questions correct. And here's just a distribution of the cardiac surgery respondents. General surgery surgeons had a similar rate of response. And thoracic surgeons tended to fare a little bit better with more of a rightward skew. However, even general thoracic surgeons were far from getting 7 out of 7 of these questions correct. So what this tells us is that there are subtleties to identification, and additional work needs to be done from an educational perspective. And this is the histogram demonstrating all of the specialties. What we also discovered was that with increasing number of resections, accuracy improved. This is true amongst cardiac centered surgeons as well as general thoracic surgeons. In order to help surgeons identify where these nodes are, over the last several years, we've worked with a surgeon, Dr. Khalid Amir, who's just retired from Southampton in the UK. And we put together a video demonstrating how to go about identifying nodal stations. We took inspiration from the ACOSOG Z30 trial. My understanding is when Dr. Darling, who's on this conference with us, started this trial, they had an educational video demonstrating where these lymph nodes were. So we took inspiration from that concept and came up with a really gorgeous 12-minute video. Dr. Amir did the lion's share of this work, and he spent most of his career educating surgeons in the UK on how to do this. And he has a collection of beautiful videos as well as 3D renderings. So this link will appear on the American College of Surgeons website in the next several days, but I'd like to take this opportunity to preview this. Again, this is a 12-minute video, and this just demonstrates some of the anatomy. We won't go through
lymph nodes.
all of it, but it identifies each nodal station. It provides data on the number of nodes that one would expect to find. These data come from cadaveric studies. We offer intraoperative photographs and video. So this
Between
is
the
just
two
a
folds of the
sample.
pulmonary ligament. The upper border of station 9.
Again, this is a
nodes, especially when the
fairly detailed video demonstrating the anatomic relationships. And the intent of this video is not to teach surgeons how to perform the dissections, but to help identify the anatomy and understand the distinctions between these various nodal stations. From a practical standpoint, what I would say is that communication between the surgeon and the nursing staff and the pathologist is key to success. At our own institution, we had performed our own survey of the prior year's results, and we discovered that we're not in 100% compliance, and we're actually far from it. But when we compare what happens in the operating room with what gets reported, most of these errors are with miscommunication. For instance, right paratracheal nodes are not separately labeled as 2R or 4R, but as sent as one station. And depending on the pathologist, the report may reflect that we only sampled one station instead of 2. There are a lot of these simple fixes in communication that can be done to improve accuracy of reporting. And most of the folks who are all on this webinar are probably already doing the appropriate operation, but it becomes a question of the practical aspects of labeling and sending to pathology. So I urge everyone to review their own cases and determine where the lapses might have been. We found that it is generally easy to fix with just appropriate communication. Just going on, previewing more of this video. Here's an example of some of the 3D rendering that is offered to kind of to help distinguish, for example, station 7 from station 8, where these are. Another accompanying video for the left-sided nodal stations should come out hopefully in the next 1 to 2 months.
Thanks, Nirmal. That content is really, really an amazing tool for all of us to use, not only to help ourselves achieve the standard, but to help teach our trainees. And potentially to share with our operating room staff too, so they have a better understanding of what they're looking at and how to label. And I would just mention too, a lot of us were trained in an era where we would label things by anatomic location, such as right paratracheal. And I would encourage everybody to move away from that and to use the actual numbers so that everyone's speaking the same language for what's going to show up on the pathology report, what's in your operative note and so forth. I think that just takes away some room for error. So yeah, and we look forward to seeing that. That link will be on the American College of Surgeons site sometime next week. And I don't know, perhaps with STS, we can share a link to that in some way, shape, or form. We'll see if that can be accomplished as well. Well, thank you. We're going to move on now to Dr. Darling, who we're honored to have with us. She was one of the lead investigators of the landmark trial on lymph node sampling versus dissection for early stage lung cancer. And it's been a little bit of time since that was first reported, but it's an incredibly important paper that informs how this standard was made. And I want to be sure that everyone out there practicing thoracic surgery is familiar with it and know that trial. Thanks, Gail.
Thank you, Linda, for that, for inviting me to participate in this webinar. Can you see my screen? Yeah, okay.
Looks good.
Okay, great. So this was, it's kind of important to know that this trial was done many years ago. And the question this trial was designed to answer was whether or not early complete lymph node dissection would improve survival in early stage lung cancer. And so this was not, does not apply to more advanced stages, larger tumors, and so on. So it was a randomized trial, multiple institutions, prospective, and we compared a systematic mediastinal lymph node dissection to a systematic lymph node sampling in patients with early stage lung cancer, non-small cell lung cancer. So the eligible patients had to have resectable clinical T1 or T2 cancers, N0 or non-Hyler N1 non-small cell lung cancer. So they could not have any evidence of enlarged or pathologic nodes in the mediastinum or in the hilum. They had to be candidates for complete anatomic resection. And prior to randomization, they had to have negative mediastinal lymph node sampling. And this wasn't done in the days before EBUS. So all these patients had their mediastinal lymph nodes sampled either by a mediastinoscopy done prior to resection or by lymph node sampling done at the time of resection. And for right-sided samples, right-sided cancers, we had to sample 2R, 4R, 7, and 10. And for left-sided cancers, we had to sample 5, 6, and 7 before the patient could even be randomized. So these lymph nodes had to be sampled, sent to pathology for frozen section, and had to be negative before the patient could be randomized. And I think this is a very important distinction compared to kind of usual practice. So they were then randomized intraoperatively either to a complete lymph node dissection, that is a formal clean out of all the fatty tissue within anatomic boundaries, or to no further lymph node dissection or sampling. And so for complete lymph node dissection on the right side would include the whole right paratracheal space, the hilar nodes, as well as the infracarinal nodes 7, 8, and 9. And for left-sided cancers, they would include the station 5, 6, so between the vagus and phrenic nerve in front of the arch and in the subaortic space, as well as the infracarinal nodes, stations 7, 8, and 9, and of course the pulmonary, the hilar lymph nodes, as well as the intralobar lymph nodes. So there are 1,111 patients randomized, 1,023 eligible for analysis. At the time of this study completion, this was the largest randomized study in thoracic surgery. All the surgeons were general thoracic surgeons and were diplomats of the American Board of Thoracic Surgery or equivalent. I won't go into that. Not surprisingly, in this sort of more modern series, the majority of patients had adenocarcinoma, but a fair number with squamous cancer. And as noted, all patients had to have an anatomic resection, most of which were lobectomy. Tumor stage, as expected, was predominantly stage 1A and 1B. There were a few 2As, 2Bs, and a smattering of 3As, which you can see were mostly in the lymph node dissection arm, and a few 3Bs. So what this really showed was that if you did rigorous pre-resection systematic sampling of the mediastinal lymph nodes relevant to the side of that you're going to be resecting, so right versus left, and had a negative lymph node sampling of the hilar lymph node, the station 10 lymph node, only 4% of patients who had negative sampling were on to be found to have a positive lymph node at mediastinal dissection. So only 4%. And the median survival showed no statistical difference. So this trial answered the question that, that if you have an early stage cancer with no evidence of radiographic lymph node abnormalities, and you do a formal mediastinal lymph node sampling, for example, for a right-sided tumor station 2R, 4R, 7, and 10R, and these are negative either by frozen section at the time of resection or by preoperative mediastinoscopy, of course, the tenar would have to be sampled at resection, that there is no survival benefit to doing further lymph node sampling. But this does not apply to higher stage tumors, bigger tumors, or tumors that have radiographic evidence of lymph node involvement, either in the hilum or in the other N1 nodes, and certainly not N2 nodes. And we also analyzed it based on T1 and T2 status, and there was again, no difference in survival. So, and I think that is really the take-home message, and there was no statistical difference in any category, whether local, regional, distant, or overall. So the summary was that mediastinal lymph node dissection does not improve overall or disease-free survival in early stage lung cancer if the pre-resection surgical staging of the mediastinal and hilar lymph nodes is negative. And I believe this forms the basis for the new recommendation of 3+1. And I want to call out this note of appreciation of Bob Ginsberg, who designed this trial. Thank you.
Thank you so much, Dr. Darling. That was a tremendous effort by American College of Surgeons and many leaders in clinical research in the field of thoracic surgery, and so important for where we are now. Last but not least, we're going to hear from Dr. Boffa, and he's going to talk to us a bit about cancer standards, cancer measures, what do they mean to accreditation, where have we been and where are we heading? So with that, we'll turn things over to Dr. Boffa, and then we'll wrap up with some discussion and question and answer.
Thank you so much. I'm not going to talk at all about those things. I'm going to talk about what do you do when you get this kind of information. And what we're really talking about is a performance report. And we get these all the time. You get this from the STS, you get your star rating, you get your pneumonia rate. This is yet another performance report. And I think this feathers into the question of what is the Commission on Cancer really doing for you? And one of the things that we do is we provide educational content and try to help hospitals improve and how do they get better. So the real point of the Commission on Cancer is to end the quality measures, which is a set of best practices that we report to hospitals, is really to just help you recognize that there's a need to change. And the standards are a representation of this. But when we get back to a performance report, what do you actually do when you find out that your care is not where you need it to be? The first thing you do is you need to look at the data. You need to really dive into what the data is telling you, and then you need to make a change to try to bring things more in line. And so the Commission on Cancer decided, we reviewed the quality courses that are available, and there really is nothing that tells you how do you react to a performance report. We all know what to do when you operate on the wrong side or where there's these one-offs. But when there's a performance report issue, there's really not clear evidence of what to do. So we took this to heart, and we actually made a course that we offer to anybody. It's been viewed a couple thousand times. And I'm going to show you the trailer.
Have you or someone you loved ever received a performance report that concerned you?
We didn't know what to do.
On July 16, 2021, at 8 a.m. Central Time, the world of performance changed forever. A quality improvement video dropped that was designed to teach teams how to respond to a performance report.
I saw the trailer and it was great. Then I saw the movie and it was amazing. Now I'm in the trailer.
Performance can be a tricky topic.
The videos discuss what performance reports represent, how to form a change team, how to interpret the data, and how to change a process to make care safer and more effective. Real-world examples are presented. as well as some parodies.
Dan, I'll take the Nile for 200, please.
The presentation will feel like a cross between a quality course, an MBA program, and an episode of Scrubs.
At the end of the day, the goal is to make the best way of doing things the path of least resistance.
This course.
So this is a link to that video. We actually discuss this exact issue, compliance. We reviewed our compliance with this standard. Actually, Ray Osoro-Jiagbon is in the video, who was mentioned earlier, who's done a lot of sentinel work on lymph nodes and has come up with some innovative solutions. So that is all I have to say, and we will circulate the link for the video, the full-length video. I promise you it'll be unlike anything you've ever seen. And it really does take you soup to nuts. How do you react to these performance reports? Thank you.
Thank you so much, Dr. Boffa. That was rather entertaining. If we can have all of our panelists turn on their video screens now, there's a few questions I want to make sure that we address and some discussion points. So one that has come up in the chat box and something that a lot of us have had as questions is, what about mediastinoscopies? What if you do a mediastinoscopy the week before you do your lobectomy? Do those lymph nodes that you checked count towards standard 5.8, or do they have to be all on the same day? And what if you didn't do a mediastinoscopy, but you had an EBUS, either that you or somebody else did along the way? Does that count towards standard 5.8? I think I'll direct that one to Dr. Veeramachaneni, if he can try to answer that for us.
Okay. Well, part of these standards is in the development standard, it has to be reproducible and easy for a surveyor to be able to address the question, did the patient have a minimum of an operation? So what we have agreed on is that if a mediastinoscopy report where you actually have gross tissue and not just cytopathology, if that can be incorporated into the report at the time of resection, we'll let it count. So there are some surgeons, for instance, who do more than a mediastinoscopy and do a fairly radical lymphadenectomy through the cervical mediastinoscopy incision. So they might not actually have nodes to get at the time of definitive operation, but the data has to be on one piece of paper. That's what we're looking for. In terms of EBUS, this is a bit of a tricky question. We know that there's not perfect concordance between endobronchial ultrasound versus mediastinoscopy versus nodal assessment at the time of resection. In expert hands, it's close to 100%, but it's not quite there. And we had actually reviewed this in our opera standards chapter. Also, there's a lot of variation in how cytopathology is reported. For example, no cancer can mean you got airway epithelium and no lymph nodes. So what does that actually mean? So you're introducing a lot more variability. So our group of experts who formulated this felt that whenever possible, go and sample the nodes that you may have stuck a needle into with the endobronchial ultrasound to make this count. So at the time of operation, if you hadn't done a mediastinoscopy and that mediastinoscopy data is not part of your report, go back to the 1+3, just sample these nodes again. And we're asking for systematic sampling, not even systematic dissection.
And one thing, this came up at my institution, it's just gonna take a little bit of heavy lifting on the part of the surgeons, and tumor board is a great opportunity. If you did a mediastinoscopy at a separate setting from the resection, just talk about it at tumor board and remind the pathologist you want all of that documented on their summative pathology report, and they just need to incorporate that, and then you meet the standard. But if you don't communicate about it and your pathologists don't understand what we're trying to achieve, it won't happen and you'll get counted as non-compliant. So a little bit of getting used to things, but it's certainly something we can all work with. Couple other questions I wanted to address, and Dr. Darling, you did touch on this in your presentation, but I really want to drive it home to people. This 1+3 is the bare minimum. And this is what we should be doing for clinical stage 1. But when we start to get into a clinical stage 2, so someone with known hilar nodes or a large central tumor, or someone who has known N2 disease that's maybe had neoadjuvant therapy, what would you consider to be the standard of care in terms of lymph node assessment that is maybe beyond the scope of the 1+3?
I think for advanced tumors that you need to do a proper anatomic mediastinal lymph node dissection. And that is especially true for patients who have had documented N2 disease and have had, preoperative therapy, and you're now taking them for a curative intent resection. You can't count on the radiation or the chemotherapy or the combination to sterilize the mediastinum, and you need to do a dissection. I would, if I might take the liberty to comment about the EBUS, I think even if you've done a preoperative EBUS, I mean, you kind of do that to rule out obvious N2 disease, but at the time you do your resection, I think it's prudent to do as Dr. Veeramachaneni said, and that is to go back and sample those lymph nodes anyway.
Yes, yeah, I would agree. So now you and I have talked about this before, that if you're, say, in a clinical trial setting and you're doing surgery for stage 3A disease, you almost should be able to take a picture of your post-resection nodal basin and have it be completely empty to feel like you've done a good job. And again, eradicating all gross disease to get an R0 resection. So I want to emphasize that the 1+3 is the bare minimum. It is by no means should limit how aggressive you might be with your lymphadenectomy, depending on the clinical circumstances. A whole lot of time left. One other thing I thought was very pertinent to address is this study that just was published a couple of weeks ago, CoC 0802, a randomized trial of segmentectomy versus lobectomy for 2 centimeter or less peripheral lung cancers. And just to point out, what are the lymph node assessments involved in that study that tell you that segmentectomy is better? Because it isn't just a blanket statement, segmentectomy is better than lobectomy. There are certain requirements that have to be met. And I'm wondering if perhaps Dr. Facktor or Dr. Boffa want to address that, or anyone who's familiar with the details of that trial. Or Dr. Darling, if you want to take a swing at that one too.
Linda, I totally missed what you just said. I was responding to Paul Lee's quote or comment in the chat. I'm sorry. Do you want to?
I'll just address it. So the segmentectomy versus lobe study that a lot of people are talking about, that segmentectomy may actually be superior for peripheral early stage lung. The requirements of that study is that they do a thorough lymph node assessment, somewhat like ACOSOG Z30, where you sample different nodal basins and they have to all be sent for frozen section and be negative. You can't just kind of look at the node and decide it's okay and go ahead and do your segment and find out later. You have to do that frozen assessment in the operating room. And then you have to have at least a 2 centimeter margin on your parenchymal margin for that to be considered superior to a lobectomy, or at least equivalent. I just want to make sure people know that, because it's not normal practice necessarily to send all your nodes frozen. And I worry that people are going to kind of go down the wrong path with that in terms of quality. We don't have a whole lot of time left. Matt, he has a few questions that have come up over the years in his role with the Commission on Cancer. And I'm wondering if Dr. Facktor might want to share with us some other common questions that have come up over the years as people try to implement the standard.
Absolutely. And we have covered a few of them already. Another one is that you sent what you thought was a lymph node, and on the pathology report, it's just adipose tissue or some other such material, not a lymph node. Does that count? Nope, it does not count, but yeah, that's okay, it happens. I've done it, and you're not sure, let pathology tell us if that's a true lymph node or not, but then keep on moving and do your operation and get as many nodes as you possibly can. Others are, gee, I didn't think it was safe to take that node that was stuck off of a vessel. Okay, first, I don't know, do you know for sure that's not a malignant node and that's why it's stuck? But maybe that's not the point of the question. Of course, don't do something that's extra dangerous, or you're worried about the recurrent laryngeal nerve. All of our standard risks in these operations, which of course are inherently dangerous, obviously do the safe thing first. And there's room, there's that wiggle room. It's an 80%, 20% rule on purpose. And again, the 80% isn't something that's scientifically validated, but it's a real good start to do what? To raise the floor, because the floor is well below 80% right now, as we've seen with the data.
Thank you so much, Dr. Facktor. I want to emphasize that if any of you listening tonight want more information, there's a load of information on the American College of Surgeons Cancer Surgery Standards program. If you search Standard 5.8, I'm certain it'll direct you to this. There are videos, YouTube videos, webinars, and lots of slide decks that you can look at and share with your team. So there's a ton of resources out there. And if you just do a little Google searching, you'll find it. Synoptic lung operative reports are coming. It's going to be a couple of years off, but that's something we're working towards. And I think it's actually going to make our lives easier. It's just going to be drop-down menus and check boxes. And then that will in turn make our cancer registrars' jobs easier. And things like the National Cancer Database will be probably contain more information that we find useful and interesting. So that's coming. And remember, 1+3, 1 Hyler node, 3 N2 nodes is the bare minimum, but definitely do more as you see fit based on the clinical situation. And in summary, on behalf of the Society of Thoracic Surgeons and the American College of Surgeons Cancer Standards Program, thank you for joining us tonight. Your investment of time tonight shows your dedication to improving quality for your patients, your practice, and your community. And I hope that your enthusiasm for quality cancer infects everyone in your work environment. Thanks again for joining us. And we'll try to answer the questions in the chat box or send out transcripts later on.
Thank you to our moderator and panelists for your participation and insight. We invite you to register for free to attend the Latin America Surgery Symposium co-presented by STS, EACTS, and ESTS on Friday, May 6th. An international faculty will discuss the latest advances in treating emergent patient cases like penetrating trauma, massive hemoptysis, and more. Register at sts.org/LatAmThoracic. We invite you to become a member of STS if you're not one already. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership. Thank you all, and good night.